So very good evening to all the participants who are attending today's program. It is our pleasure to have Dr. Rahul Deshpande here today with us for conducting a very small and informative session on kidney disease and the importance of the awareness and how we all need to be aware about the fact that how important it is to live well with kidney disease. Dr. Rahul is our young nephrologist and is takes a lot of interest in talking to general awareness about kidney disease across, and we have also done number of awareness programs with Dr. Rahul. And with this small introduction, sir, I would like to hand over the session to you so that our patients can get the maximum benefit from your small talks. Thank you so much.
Thank you very much. A short introduction of myself. Dr. Rahul Deshpande. I am a consultant nephrologist. I am working from Andheri to Bandra at multiple hospitals. So we will directly touch to the topic. So today we will be discussing about an important topic, that is dialysis. So now, what is dialysis? We'll start with what is exactly this dialysis means. So dialysis means uh, the process in which the toxins from the blood are removed. These toxins are named as a creatinine, blood urea nitrogen, uric acid, phosphorus, potassium, metabolic acids, and water, which are supposed to be removed by kidneys naturally. But with unfortunate people, non-functional kidneys, these toxins are to be removed with the process called as dialysis. The other name for dialysis is the renal replacement therapy, because it is nothing but it is doing the function of kidney. So basically there are two main types of dialysis that we usually do. One is hemodialysis and second is peritoneal dialysis. So whenever the word hemo comes, hemo means blood. So in this type of dialysis, what we do is we circulate the patient's blood through a machine. This machine works just like the kidneys, like it removes all the toxins including the water, and the purified blood is returned back to the patient. This is the hemodialysis. And second thing is the peritoneal dialysis. In peritoneal dialysis, what we do is in peritoneal dialysis, usually we put a catheter in the abdomen and we take the help of a peritoneum. Peritoneum is nothing but the inner layer of the abdominal wall. So we put water inside the abdominal wall, and this water is kept for some specific hours, maybe 4 hours to 8 hours, variable depending upon the patient type, and then it is drained out. This water along with it takes the creatinine, blood urea nitrogen, phosphorus, and all the waste in the blood to the drain. So these are the two types of dialysis: abdominal or peritoneal dialysis and a hemodialysis. These are two large topics. So today we will be discussing more about the hemodialysis rather than discussing about the peritoneal one, because hemodialysis is something which is more rampantly used. So we will be discussing more about the hemodialysis today. So now, as we know as we have some idea now what is dialysis, we will go ahead with the hemodialysis. Like in hemodialysis, when do we advise? We means a nephrologist advise a dialysis for any patient. So there are certain diseases where we usually advise the dialysis. Acute kidney injury. Acute kidney injury is nothing but a kidney injury which is temporary. The acute word tells the story that it is a temporary kidney insult. So practically any possible severe illness, like it can be a severe malaria, it can be a severe gastroenteritis where dehydration has happened, it can be a severe dengue, it can be any fever which is severe enough, it can be a severe heart attack or a liver failure. Especially in ICU settings, we see the patient of acute kidney injury. If it is severe enough, that may require dialysis. Second is chronic kidney disease. Chronic kidney disease is it is slowly worsening creatinine and slowly damaging kidneys. So all over the world, the most common causes, as most of us must be knowing, that diabetes and blood pressure are the most common causes of a chronic kidney disease. So in this setting also, when the kidney function goes down significantly low, we have to start patient on a dialysis. And third thing is when the kidneys are not actually involved, but there are some toxins or poisons, or I will say drug overdoses, where we advise dialysis. Just like methanol, which is an adulterant in alcohol, or ethylene glycol poisoning, or some drugs like barbiturate, lithium, and there are many more. The list is used. So there are three diseases specifically where we, or situations where we advise dialysis: acute kidney injury, chronic kidney disease, and a toxins or a drug removal. So now we go to the next, that is indication of dialysis. Now, indication means when to start dialysis, at what particular moment we advise a particular patient to start the dialysis. When the kidney function is significantly deranged. What is significant? Less than 15% of your kidneys are functional, and along with that, any of these which we will be discussing now, indication develops, then patient should be started on dialysis. So most important indication I will start with is a fluid overload. So what is fluid overload? Fluid overload is nothing but accumulation of water in the body. It usually starts with the feet, then it comes up with thighs, and then ultimately in the lungs, which is called as a pulmonary edema. So basically, fluid overload, where kidneys are not able to throw out the water effectively. That's why that has to be removed by dialysis. Second is a hyperkalemia, where similarly the potassium accumulates instead of water. Third is a metabolic acidosis, and fourth is uremia. Now, what is uremia? Uremia is basically a technical term. Uremia means once this toxins start accumulating because of dysfunctional kidneys in the body, so it causes some signs and symptoms in the body, which we call as a uremia. It can start from the mildest of the vomiting. It can be a persistent nausea, persistent vomiting, loss of appetite, cachexia, increased sleepiness or drowsiness, what we will call. And in the severe most cases, it can be a convulsion, what we call as a seizure, or it can be a coma also. So these are the indications, along with the kidney failure, when we advise dialysis to a particular patient. So now next we'll move on to the technique of dialysis. Now, how is it done? So most of our people don't know how the dialysis is done, and that's why they carry unusual fear of dialysis. So that should be removed. So the technique of dialysis is basically there has to be one access of dialysis. Now, what is access? Access is nothing but it is in the patient, from which the blood has to be fetched to the machine. The blood has to be sent to the machine for purification. So there are three types of access mainly. One is a temporary jugular catheter. In this, what we do usually, we put a catheter under local anesthesia. In a big vein, what we call as a jugular vein. It has two ports. So one port is connected to a tubing. Blood goes in the dialysis machine, purified, and by second port, that purified blood returns to the patient. So this is a temporary catheter. Second is a permanent catheter. It is slightly similar to the temporary catheter, but it is much durable and much safe as compared to a temporary catheter. And third is a AV fistula. Now, what is a AV fistula? Now, AV fistula is basically in hand. What we do a minor surgery, and we join the arteries and veins, that is blue veins and red arteries. So once we join it, the veins get engorged or veins get thickened, and that can be used for a dialysis easily. So best access for a dialysis is usually fistula. Second is in preference as a permanent catheter. Usually we put permanent catheter those patients who are not good for a fistula formation, just like very old age, who have a thin arteries and veins, who are old diabetic, who are atherosclerosis. So for them we advise permanent catheter, and temporary catheter is just for a emergency basis. Like if patient suddenly comes with a creatinine of 10, 12, and then he needs to be started on dialysis, then a temporary catheter is put. So this is the access. The second thing is a machine, the dialysis machine. Nowadays the dialysis machine is very sophisticated and safe. So there is nothing that you should have a fear about it. So dialysis machine, and to attach that dialysis machine there is a dialyzer. It is a cylindrical instrument what we use. So in this instrument there is a flow of blood from the access of the patient, and in counter current direction there is a flow of a dialysate. Dialysate is nothing but, you can say it as a water, a fluid artificially created by the dialysis machine itself. So what happens, when the blood goes down, the dialyzer goes up. So by counter current mechanism, by the process of diffusion, all the toxins, blood urea, nitrogen, creatinine, phosphorus, potassium and acids are removed into the dialyzed water, and ultimately that dialyzed water goes into drain. So this purified blood is again returned back to the patient. This whole process is called as a hemodialysis. So after knowing the technique or the procedure of dialysis, we will move on to a more important topic, that is do's and don'ts of the patients who are already on dialysis or who are going to be on dialysis in near future. So first we will start with the do's. So do's, will start with the diet. So usually in dialysis patient, what diet we usually ask or recommend is, there is definitely certain amount of water or fluid restriction. Now, why water restriction? So these patients are having kidney issues, so they are not able to produce enough amount of urine. So if they drink more, they tend to accumulate more water in the body in form of swelling, and this can be dangerous. That's why there is restriction, certain restriction to each individual patient as per their nephrologist. So fluid restriction. Second is salt restriction. That is also important as most of these patients are hypertensive. Third is a diabetic diet. Most of these patients are diabetic, so it should be followed. And fourth and important is a high protein diet. So usually when we save the kidneys, the patient is not on dialysis but certainly has some kidney issue, we ask for a low protein diet. But once he is shifted or put on a dialysis, we ask for a more protein diet, that is 1.2 grams per kg. What is the usual requirement of normal body? It is 1 gram per kg. So 1.2 grams per kg of protein. And mostly patients are advised a low potassium diet because they tend to accumulate potassium also. So this is the diet that we start with in the do's column. So what is next in do's? So next in do's is, actually each dialysis patient uh, usually should know his overall behavior during dialysis. Behavior means I am saying about the symptomatology and other things happening during dialysis. Like, for example, when a patient comes for dialysis, his weight while going into dialysis and while coming back from dialysis, that is very important. That has some difference because, as I have discussed, that these patients tend to accumulate water, so we remove that excess of water with the help of dialysis machine. So the weight while going for dialysis is definitely more than while coming back from the dialysis due to removal of water by machine during dialysis. So this weight, this entity is called as a dry weight. Now, what is dry weight? Dry weight is the weight of a patient where there is neither excess of water in the body nor less of the water in the body. So this happens naturally in human body, but when kidneys are dysfunctional, then definitely there is water accumulation. So that has to be removed by machine. That is dialysis. So pre-dialysis weight and post-dialysis weight are very important. So this dry weight has to be titrated over the period of time once patient is started on dialysis. For example, if patient is having recurrently low blood pressure during the dialysis session, or he is having abdominal pains, cramps, so most probably uh, excess of water is removed from his body than required. So this dry weight has to be titrated up slowly. On the contrary, even after doing a dialysis twice or thrice a week, if patient is having significant swelling in the legs, he is becoming breathlessness, he is having breathlessness all the time, then most probably his dry weight has to be optimized downwards. So this dry weight patient himself should be knowing rather than a nephrologist or a dialysis technician over the period of time. Second thing, intradialytic complications means any complications happening during dialysis. Just like we discussed, reduction in BP during the end of the session, or increased BP during the dialysis, or any breathlessness, or any BP fluctuation, any cramping. This you should be watchful and should note it down and should point it out to your nephrologist so the dialysis prescription can be changed. So these are the do's. The next important thing in do's is access care. Access, just like I said, it is something through which the blood is transported to machine for a dialysis purpose. So access, we call it as a second heart of a dialysis patient, because without a proper access, a dialysis cannot happen. So care of access is very important. So if you have a temporary or permanent catheter, you cannot have an overhead bath. You should avoid swimming, because if any water goes inside this catheter, through this catheter to the blood, there is a high chance that you may develop infection. This is not with the fistula. With fistula, you can do swimming also. You can take overhead bath also. So along with that, with a catheter, you should maintain a proper hygiene, and dressing should be done regularly during the dialysis sessions. So this is the access care, what I wanted to say. Then next comes, after access care is, we will talk about we have spoken about the do's. Now we will talk about the don'ts. So as far as the don'ts are concerned, we usually advise our dialysis patient to not to take diabetes medicine, especially strong diabetes medicines like sulfonylureas or insulin before dialysis on a day of dialysis. And we also ask them not to take a BP medicines before dialysis on the day of dialysis. Why? Because after water removal, the BP itself comes down. So we don't want the patient to land into low blood pressure. That's why we ask for that. And even dialysis machine removes the glucose from the blood. So that's why even the diabetic medications should not be taken on the day of dialysis, before dialysis. After the dialysis, BP and sugar medicines are supposed to be taken like the usual doses. So this is the precaution, or the thing that should be kept in mind by the dialysis patient to avoid the troubles. Now second thing is, most of our patients, what they do, if they develop some viral fever or some cold, so in that case they skip the dialysis. But this can be really dangerous. Skipping the dialysis should be prohibited unless and until your nephrologist is your nephrologist is knowing that you are not taking this dialysis with a proper precaution. Then it is a different thing, but otherwise dialysis should not be skipped for minor illnesses, minor viral fevers, because the simple logic is everyone's kidney is functioning 24/7. But on dialysis, we usually do it for a twice or a thrice in a week, and that to 4 hour session. So hardly 8 to 12 hours of exposure to machine. Rest of the time, all toxins and water is getting accumulated. So if we miss dialysis in between that also, then it can be troublesome. So it should be avoided. So this is the don'ts that will. Now we will come to a more important thing, that is the misconceptions. Misconceptions about dialysis. There are very much misconceptions about dialysis, or prejudiced minds about dialysis. So first of all, most of the patient, when we ask them to start dialysis, their first question is, we don't want to start dialysis because once we start dialysis, then we will have to continue it lifelong. Now, first of all, this question itself is not correct, because uh, if a nephrologist is advising you a dialysis, then it is a life-saving measure. So if we don't do it, it can be life-endangering. So definitely, whenever a nephrologist is saying that dialysis has to be done, it has to be done. Now the second part is whether it has to be continued forever or lifelong, or it can be stopped in between. So people think like, yeah, as if one dialysis is done, then body gets accustomed or acclimatized to it, and then dialysis cannot be stopped. It is completely a myth. It is a wrong concept. Look, as we discussed before, there are temporary kidney insults and a permanent kidney insults. If the dialysis started out of a permanent kidney insult, yes, dialysis has to be continued lifelong, twice or thrice a week. But if it is because of a temporary kidney insult, then once the kidney recovers because of medicines by a nephrologist or naturally, then dialysis can be stopped, and that we usually do in setting of acute kidney injuries. So it is not like that. When it has to be started, it has to be started, and if it is a temporary renal insult, you may get rid of dialysis after certain amount of dialysis done, as per your nephrologist advice. Now, second thing, most of the patients or relatives think that once this dialysis is started, Then quality of life or functionality of the patient. Functionality means whatever he's perceiving. If he's younger, then his education, his goals, his aims, his dreams, or his profession or his job has to be sacrificed. So this is again totally wrong. So except those 8 to 12 hours in the week when patient has to be on a dialysis, except that for rest of the days and even on the day of dialysis, patient is fully functional. So he can pursue his studies, his education, he can follow his dreams, he can do his jobs. Most of our patients are doing jobs if they are on dialysis also. So this is absolutely wrong. Uh, the second thing I spoke is the quality of life. So I can definitely tell you the quality of life is, suppose I see a patient who is having a creatinine of 5, 6, 7, 8, 9, or maybe 10, who is not on dialysis, who is yet to be started on dialysis. Once I start dialysis to same patient, on the contrary, his quality of life improves. Now how? Now these patients, because of accumulation of toxins, they are not eating well. They have excess generalized weakness, fatigability, water accumulation, water restrictions, and multiple things. But once the dialysis is started, these toxins are taken care nicely. So they start having a good appetite, a hunger, and out of this hunger and appetite, even we advise a high protein diet in a dialysis patient. So ultimately, they again gain a healthy weight with a healthy muscle mass, healthy bone mass. So their mobility as well as their functionality as well as their quality of life improves, and they can do and pursue their job and professions as usual, except those few hours of dialysis. So this is the second thing that I definitely want to clarify. Third thing, usually patients ask us कि once we start the dialysis, we cannot roam around out of the city or out of country. So this is again wrong. Uh, Look, once the dialysis is started and once the nephrologist has said you that lifelong this dialysis has to be continued, then it has to be continued wherever you go. So it is simple that if you want to leave the city or country, you can do that, but with the precaution that twice or thrice weekly dialysis, whatever the prescription or doctor has advised you, that has to be continued wherever you go. That's all. So these are the few myths that the patients and relatives usually think of. So now to end the session, I will just highlight few things, or I would like to tell the few things that dialysis is not the death sentence. Most of our patient thinks that if dialysis is started, the patient is not going to live for longer duration, or the quality of life will be hampered. So as I have discussed previously, it is not the case. Most of our patients have good quality of life, and they have almost similar quality of life like their non-dialysis counterparts. So it is not like that. Don't think it or don't take it like that. Okay. Anyways, when the dialysis is advised, it has to be done. It is not an optional thing whenever nephrologist advises a dialysis. So if we don't do it, it can be life endangering. So on dialysis also, life goes on nicely. For few frail people who are above 80, who are above 90, with rainy season on in a Mumbai like area, there can be certain difficulties that can also be overcome with a home dialysis facility. With this sophisticated machine, the dialysis has become very safe. So even dialysis can be arranged in a home settings, so that you need not travel all the way to dialysis center twice or thrice weekly. So on dialysis also, life goes on, and not just goes on, it goes on nicely with maintained quality of life and with a prolonged life expectancy. So I will end my talk over here about the dialysis. So forget about all those myths and hearsay things. Dialysis, when required, please do it as per your nephrologist advice, and it has to be continued unless and until you have a prospect of doing a kidney transplant. Thank you. So many people, so the question is the dialysis safe? So most of the people think that it is not safe. So I can tell you from my personal experience that we do dialysis not just for a particular age group. We do dialysis starting from 10-year kid to a 70, 80 or 90-year-old man. So when we do dialysis, it has to be individualized for a particular patient according to his situation, his heart issues, his diabetes status, his blood pressure medications. With all those things taken care nicely, dialysis is absolutely safe nowadays. Why I am using word nowadays? Because now the machines are quite sophisticated. So it is quite safe nowadays with all sophisticated machines and well-equipped hospitals to tackle any emergency if it happens. So dialysis is perfectly safe. No, actually, with kidney dysfunction or if a severe renal involvement is there is an acidosis. Acidosis and acidity are completely different things. Acidosis means acid in blood. So that has nothing to do with the acidity that we usually see with the abdominal upset and all those things. Yes, but a severe kidney failure, you can have more gastritis as compared to the other people. What is gastritis? Gastritis is nothing but the stomach upset or dyspepsia or excess of acidity. That can be easily managed by either of the two things. If renal dysfunction is severe, with a proper dialysis and also with a antacid medications that we usually prescribe for any kind of acidity. Any further questions? I think we are done with the questions. Okay. Okay, so I think we are done with the questions also. So thank you everyone for inviting me for this nice session, because definitely as far as the dialysis is concerned, there are many myths and people think like once dialysis is started, it is almost like a death sentence. It is not like that. You can have almost equivalent quality of life like a non-dialysis peer or non-dialysis friend of yours. So don't have that fear in your mind. Don't be prejudiced. Don't be have a prejudiced mind as far as the dialysis is concerned. And please follow the advice of a nephrologist and do dialysis safely. Stay safe and stay healthy. Thank you.